Setting up your meeting. We go to YouTube to confirm. Yes. And we get on with the Zoom recording. Perfect. So Ritu ma'am can start.
Yes, sir.
Yes.
Good evening, sir, and good evening, all the participants. We are again back with one more pre-Congress webinar where we are going to see that before our session, the 6th and 7th in the Kolkata for CCOMT, where we are going to take the elbow and the wrist and hand. For that, as a preparatory webinar for understanding of anatomy, biomechanics, and the pathomechanics, that how these joints work and how their function and the dysfunction as the part of the pathomechanics can influence the patient's life as a functional life. So just
So we have a short pause. As madam might have got an important call or something.
sorry, sir.
Yeah, it's fine.
So, we are going to learn more about the wrist and hand today. And definitely, our second session will be on the elbow because yesterday itself on the Instagram and on the as a part of elbow and the shoulder connectivity with the bicep group of muscle that sir has explained, because that is the very important part of our learning for till wrist and hand, because the movement of that these the flexor group of the muscles which related to the shoulder, elbow, and wrist and hand influence each other, because if we see as a part of the structure or region or the function, so we cannot leave it these sessions, that these all the sessions are very very important for learning about wrist and hand. So today we will see that how the influence of the pathomechanics of wrist and hand can create a dysfunction when the patient is not able to hold their grip is weak, they are not able to hold the things, or maybe there is some fractures because of that, or maybe some neural component like the median nerve, which is a very common condition we see is as a part of the carpal tunnel syndrome. So these are the things as a part of articular myofascial and the neural we think we see in the wrist dysfunction that patient is having a problem, or after the fracture, how the mobilization or how the rehabilitation work is very very important part for the wrist and hand, because as we know that our brain understand the language, the neuroplasticity, our brain is basically there is a major part which is covered the captured by the wrist and hand. So there the hand working is very very important. So these are the things which very very important we have to be careful when we are going to treat the patient who are having a wrist and hand problem. And after that, if they are having cast removal, how the rehabilitation is important for the wrist and hand, not only for these things, the patient, the neural conditions where the stroke patient, so their recovery, their hand movements plays a major role, because when they are not able to hold their things, they feel depressed that they are not able to do their work themselves. So these are the things. For that I will say that understanding of wrist of hand mechanism is very very important. And for Kolkata session, definitely it will be, because it's our last module for our CCOMT, where we are going to complete our all the sessions with the wrist and hand. So that is also very important part of AMPT, where we are having a graduation ceremony also. For that, we will end up that module with the wrist and hand. So today we are going to see that how the introductory part, that how the hand movements, because everybody knows their we can see and we can feel and we can touch our hand. So for that, if I will take the model in my hand, so I think this model is more beneficial, because with this I can easily explain that how these movement or how these structure, that surface palpation is important when we are seeing our patient, they are having a pain. Either the pain is because of the ligaments, joint, capsule, myofascial, and the numbness with the neural component. So in this also we see that the distal ends, because this is the bone that, because by the we have yesterday seen the elbow structure of the elbow, because the proximal joint of radial ulna is connected to the elbow, and when it is coming towards the hand, so these are the parts where the distal end of the radius and the ulna. So radius is towards the thumb side and ulna is towards the little finger. So that is the part that where the distal part of the radio ulna is there, at that their attachment with the bone. There is the bones which is in our palm. We can feel it that there are the bones which makes the two row, proximal versus the distal row of the bones, that is known as the carpal bones, which you can see in this picture also. And as well as after that, that the five rays are coming, that is known as the metacarpal bones. Metacarpal because they are attached to the carpal bone. So these are the five metacarpal bones which is connected to all the digit with the thumb. And after that, we are when we are talking about the fingers, so they are the phalanges, that is also in divided into the three part, with the proximal, middle, and the distal as a part of the pip, dip, and mip. So these are the things which we see that in our hand movement. And then we see that there are the joints, because these are the bones and structure we have seen, but there are the some joints which are making them the connectivity with each other. So there are the, because there is a radio and this is the carpal, so a radiocarpal joint, then mid-carpal joint with between the carpal bones, and then carpometacarpal joints, which joins the thumb and other digits also, and metacarpal to phalangeal joint, which is attaching with the phalanges, and after that in between the phalanges there are the joints, so they are known as the interphalangeal joints. So these are the movement as a part of the bones and then the joints. And then we will see that these joints are, they are having their own they are the type, their articulation, proximal articulation, distal articulation. So these are the things are very very important to understand about these things, because these articulation gives us the idea when we are going to give the joint mobilization, if there is a articular dysfunction, where we use the distraction and the compression and we need the glides. So that time these glidings are mainly we see about according to their bones articulation, as a part of the convex concavity of the bone, with in which direction we are going to give the guide, and which type of the joint, that is also important, because according to that we see that these joints are related to work. So in this the movements are also the flexion extension. Suppose this is the ellipsoid joint, so it will be the flexion extension and abduction adduction movement, because here the concave and convex bones, they are fitting together according to their structure, so they fix like the ellipsoid bone. And if there is a gliding is needed, so then that time also, because these the carpal, the mid carpal bones in between, there is we can give the gliding. And then there also the flexion extension and abduction adduction is movement is provided. Then carpometacarpal joint, where the first metacarpal and the second, third, and fourth, and the fifth metacarpal, they are in the proximal articulation, and their distal articulation with the trapezium bone. So these are also the joints where the flexion extension and somehow we can create the circumduction also, and the opposition, because there is a thumb involvement. So they are the abduction, adduction, and the opponents, the muscles which are providing, which can allow the movement to touch the other fingers by the thumb also. So these are the things. And if we are talking about the metacarpophalangeal joints, which are also articulating with the carpals, are articulating with the phalangeals, and these are the also joints like the ellipsoidal joint. Here also the flexion, extension, abduction, adduction is available, and circumduction. So it means that all the joints, according to their articulation, they provide the movement, flexibility of the movement of that particular structure, and the type of the joint, which type of the joints, according to that we see their movement is available. So these are the joints which are present in the wrist complex, that is the saddle joint, condylite joint, and hinge joint, because we know that the hinging where with the forearm to wrist, it is dividing is like a hinge joint, gliding joint, intercarpal joints in the hands, that in between the carpal bones there is a gliding is available, condylate joint, where the example like the in the wrist versus the metacarpophalangeal joint and the metatarsophalangeal joint. So that is, these are the joints which provides the movement. So this is important for the articular treatment when we are going to give the articular mobilization with the movement. So that times these joint structure gives us the idea that in which direction the glide will work. And this is the radiocarpal structure where the radius, you can see it that how the radius is, this is the radius, you can see it there. This is radius, this is the ulna. So there, the proximal surface is the first row which is attached with the carpal bones. They are the proximal row, and upper row where also the carpal bones are, they are known as the distal bone. So in this, you can see in this picture that this is the radius surface is more than the ulnar surface. So it means that radial, the lateral, this is the lateral side of the radius, and this is the medial side of the radius. So they are articulating with the scaphoid bone, and scaphoid itself is having a larger area than the lunate and the triquetrum. So this is the way that radius most of the area articulating with the scaphoid, and somehow the medial side is articulating with the lunate also. And this is the ulna. So their side is there is a articulating disc in between the radius and the ulna, and it is also articulating with the triquetrum, and here is a small bone which is the pisiformis also available. So their articulating surface, radius ulna articulating surface with the proximal row of the carpal is mainly because when we do the movements as a part of the biomechanics, when we do the flexion or the extension, at time this proximal and the distal row, they are slightly shift, and in the extension they are visible where we can palpate these bone. But when we are doing the flexion, so that time that distal row is coming towards the proximal row. So that time we cannot palpate the scaphoid. So this is the way that articulation according to the joint surface is most important, which providing by the radius to the scaphoid and somehow some part to the lunate also. And there is a triangular fibrocartilaginous, you can see that this is between the head of the radius and the ulna. In between the radius and the ulna, this is the cartilage sheath, and which is formed by the articular disc that binds the ulna and radius together with the radioulnar and ulnocarpal ligament. So this is also very much important whenever we see the patient who are having some fractures. After that, they are having a pain. So because of these cartilage complex, they feel that area, because we can see it that as a part of the facial restriction, facial mobility is restricted in that area because of the adhesion in between this radioulnar ligament and ulnocarpal ligament. Because of this TFC, the triangular fibrocartilaginous complex, which add on like a structure, and they cover the most of the ligaments which are joining with the ulna to the other bones, like the distal row of that particular bone, from which these ligaments are going to attach as the ulnar collateral ligament, ulnar triquetral ligaments, and ulnar-lunate ligaments. In that, these ligaments are attached to the ulna with this triangular fibrocartilage. And also the extensor carpi ulnaris tendon sheath is also coming towards that. So it means the patient who are having in the extension side, they are having a pain while doing the extension, they are having a pain towards the ulnar side. So that can be because of this TFCC can be because of that there is a adhesion, or maybe there is a some restriction as of like after the arthritis the patient is having pain. So that can be the cause for their pain, that is the triangular fibrocartilage. And this is the joint capsule, like the synovial joint. The capsule is double layer. Here is the layer is the double, which is also with the fibrous outer layer attached to the distal, because first they can, this capsule layer can be articulate with the distal end of the radius ulna and the proximal row of the carpal bones, that you can see it. And the internal layer synovial membrane extend up to the margin of the articular surface. So these are the joint capsules which are also providing the stability to the distal end of the radius ulna and the proximal row of the carpal bones. And this is the mid-carpal joints. As a functional unit, they are an anatomical unit because it does not form a single uninterrupted articular surface. So they are articulating with each other, and they are composed with the bones, with the proximal and the distal bone. And they are making the, in between, they are making the mid-carpal joints that you can also see in this. And their articulating surfaces are proximal, where the scaphoid unit and triquetrum, and distal is the trapezium, trapezoid, capitate, and the lunate, which provides the stability to the capitate also, because capitate, it is in the center. So C is for the center, and capitate is also in the center in the distal row. So it provides the stability whenever we are going to hold something. So that time these bones give the stability like that, making the arches of the hand also. So these joints provide the distal row, the capitate, and they joint provide the stability to the hand also. And this is the intercarpal joints, which you can see it that between the carpal bones of the proximal row, between the distal row, and the midcarpal joint between the proximal and the distal row. In between that, the rows, distal rows for the carpal bone, and the pisotriquetral joint, which form the pisiform with the palmar surface of the triquetrum. And there are ligaments which also provide, because if there is a instability, there are the clicks are coming when the patient is doing because of degenerative changes, because of osteoarthritis. So the morning stiffness and the hands are getting the clicks. So that time there is an instability because of these ligaments. So these ligaments, they are creating a instability in the hand. So they are also providing the stability factor versus the instability factor if they are in the, there is a osteoarthritis, rheumatoid arthritis. So that time these ligaments, they are not providing the stability to the hand. That's why the patient is having a stiffness and some deformities after that, if they are not treated, and after that they are having the deformities in their fingers also. So these are the ligaments which attaching to the radial side or the ulnar side. So both the sides there are the ligaments which are attached to the rows of that particular carpal bones. So you can see that with the radius, the radial collateral ligament, and also that radial capitate, because the radius is attached to the capitate, which is in the distal row. Scapulolunate, because it is attaching to the both the scaphoid or the lunate ligament, and it is also with the triquetral ligament. So these are towards the radial side, and these are the ulnar side that is also attached to the rows of the triquetrum, or they are making the triangular fibrocartilage sheet. In between that ulnar side ligaments are getting the support with this TFCC. And this is the triquetrum, and you can see this is the capitate, and with the capitate also there are the ligaments which attach with the capitate versus the scaphoid, and with the unit also. So these ligaments which provides the stability to the hand. And these are the volar ligaments of the wrist complex, and this is the dorsal wrist ligament which forms the V shape, which forms the V-shaped ligament support as a horizontal, adding to the radiocarpal stability. And this volar ligaments, which makes the wrist complex, which are the three bands of the volar radiocarpal ligament, radioscaphocapitate ligament, which we have seen in our previous slides, radiolunate, radioscapulate. So they make the volar ligaments, which are towards the radial side. So these, the two intrinsic ligaments like the scapholunate and the lunotriquetral are credited with maintaining the stability of the scaphoid. So when they are adding to the, in this picture, you can see that this structure, that how they are providing the stability. So means they are for the they are known as the intrinsic ligament, because they are attached with the intrinsic muscles which are providing which are in the inserting and originating in the hand itself. So with that, these ligaments work to provide the stability of the particular, if we want to hold something, or like the making the grips. So that time these ligaments plays a major role. And this is radiocarpal capsule and ligaments. So these are also as a ulnar collateral ligaments which run from the triquetrum, from the ulna to the triquetrum and the pisiform. So this is ulnar collateral ligaments. This is palmar radiocarpal ligament, which radius to the carpal row. It is attached. This is radial collateral, like ulnar side, this is the ulnar collateral ligament. Radial side, it is the radial collateral ligament, which run from the radius to the scaphoid and trapezium, and this run from the ulna to the triquetrum and the pisiform, because they are just making the boundaries, like these ligaments are making the boundaries like structure. So they are holding the stability of the hand by providing the stability. And this palmar radiocarpal ligament, that is also because with the radius to palm to the carpal bone, so that is also provide the stability. So these are capsule and the ligaments which provide the stability. And radiocarpal joint is not crossed by any muscle. So this ligament is, there is a no muscle which is crossing. Only the flexor carpi ulnaris muscle is the only muscle that crosses the radiocarpal joint. So this is also very important thing when we are seeing about the ligaments. So that means that no other muscle than the flexor carpi ulnaris is crossing the radiocarpal joint and attached to the bones of the proximal carpal groove. So this is the also important point here to whenever we see that the myofascial structure. So there is, first we have to treat the articular, then we have to see that the flexor, because it is from ulnar side and this is the flexor of the hand. So then that time this muscle which are coming towards that and inserting and crossing the this radiocarpal joint is important to release if there is any adhesion in this muscle or any tightness. And then we will see that one more very more specific important thing that is very important when we see that after some fractures or cast removal, the patient is having some they say normally say that I am having some deviation in my hand. I feel that my hand is deviating towards the little finger, or my hand is deviating towards the thumb. So that time these things comes in the mind, that is known as the ulnar negative and positive variance. So these variants are also very important part, that is very easily we can understand that ulnar negative variance, where the ulna is short in comparison with the radius at the distal end. And if there is a ulnar positive variance, then the distal ulna is long in relation to the distal radius. So it means it decided by the ulnar negative and positive variance with the size of the ulna, which you can see in this picture also, that there is the smaller ulna and there is a bigger. So if ulna is short, negative variance; if ulna is long, that is the positive variance; and if both are the equal, then there is a neutral variance. So this is also a very important thing, and this noticeable after some fracture or after the radius head fracture, and after that that fracture is regenerating in the form of the shortening form of the radius. So after that this ulnar deviation comes, and the patients normally they keep their hand deviated towards the ulnar side also if there is a shortening, or if there is a the positive variance, ulna is long, then it will be deviated towards the radial side. So this is also you can see in this picture also, ulnar positive variance versus the ulnar negative variance, where the distal radius fracture that healed in the shortened position, and that time also the ulnar positive variance, because the ulna is bigger than the radius. And short ulna may result in the abnormal force distribution in the radiocarpal joint with the degeneration, or maybe the avascular necrosis of the lunate, or the Kinbox disease has been associated with ulnar negative variance. So if the patient is mentioned with the Kinbox disease, so there also the, or the avascular necrosis of the lunate head, so that time also the negative variance of ulna will be noted down. So this is the radioulnar deviation of the wrist. So how the wrist is deviated towards the, so that time that proximal row of these carpal bones are also shifting like that with the radial deviation of the wrist. So if my wrist is deviated towards the radial size, so that time the flexion of the scaphoid muscle should be scaphoid must be appear shorter, because it makes the shortening of the scaphoid bone. Because if I am deviating, so it will not get the proper space to come out, so it will be shorter. And when the scaphoid extends during the deviation, so that time it will be in extended form, it will be easily palpable. So according to the radial and ulnar deviation, we can palpate the scaphoid in that position when with the flexion versus the extension position. And this is that after that we are reaching towards the finger anatomy. That is also very, very important part, that as we see our fingers, they are joined, the phalanx, their proximal versus middle versus the distal phalanx. So there are also the ligaments which provide the stability. They are known as the collateral ligaments, which provide the stability to the fingers. And there are the tendons which are reaching towards the finger, which are like the lumbricals. So there, these tendons also plays a very, very important role, because there are the tendon, that is the flexor digitorum superficial versus the flexor digitorum profundus. They are tendons because they are coming towards the forearm and inserting in the as a form of the tendon. So then they are as a tendon, they are reaching in the palmar area. So but the FDS, the flexor digitorum superficial, it is not going till the distal phalanx. Because of that, when we trained the patient who are having a grips problem, so because of this, if there is a weakness of the flexor digitorum profundus, so they will not allow the fingers in the flexion position, that the distal phalanx. So until the middle the superficial is tendon is coming, but after that only the profundus is going on. So these are the things. And there are also we see that there are the pulleys, which you can see that the A1, A2, A3, A4, A5 pulleys, they are just making the movement smooth with the movement of abduction, adduction, or flexion, extension, or the circumduction. So these pulleys make the stability of the finger also. So in this also we see that the A1, A2, A1 is the at the head of the metacarpal joint, and A2 you can see it here. This is the A2, which is the volar mid shaft of the, this is the proximal phalanx. This is the proximal phalanx part where the A2, and distal proximal phalanx, there is the A3 and A4, which you can see that this is in the centrally in the middle phalanx. So this is in the A4 is in the middle phalanx, and this is the A5, it is in the distal phalanx. So A3 and A2, it is attached to the proximal and distal head of the proximal phalanx, and A1 is towards the metacarpal. So these are the joints, and there are the cruciform pulleys also, which makes a cross type structure. That also the for the tendon gliding, these uh, cruciform pulleys provides the stability. In between the tendon is gliding. So if these pulleys or these ligaments, they are in the instability, so that time the deformity comes in the different form of the deformity in the fingers come, because of these collateral ligaments and because of these pulleys. So that time the flexor digitorum and the flexor digitorum superficial tendons become stuck in these pulleys. So the patient says that my finger is stuck in this position. So at what point this finger is in the stuck position, that will gives the idea that either the cruciform pulleys or the annular pulleys, which is in the middle part or the distal or proximal part of the proximal phalanx, or in the middle or in the distal phalanx. According to that, we have to see that these ligaments, which are the crucinate ligaments, cruciform pulleys, so they are not providing the gliding properly. So that is also very important to see that how these flexor tendon, which are close to the bone, which provide the functioning of the annular pulleys for the smoothing. They allow only the minimal amount of migration or the joint axis movement, and also that these tendons are, if it work efficiently with the long tendons, then the patient is having a right grip. And then we will see that after this pulleys, there is a one more thing as a part of anatomy is very important, that is the carpal tunnel, which normally in our patient, we see that the patient is having a carpal tunnel syndrome, where no, only we see that this is the nerve entrapment, the median nerve entrapment. But here you can see that there are so many other structure which can also cause the carpal tunnel syndrome, like the all the tendons which are entering in this tunnel, they are also is the making the part of it. And also there is the canal, which is this is in the volar wrist, this is that, this is the median nerve, and there is the synovial sheath of the flexor of tendons also, flexor digitorum superficial tendon and flexor retina, this is the retinaculum, in between this is coming, and this is the ulnar nerve where the guinan canals is there, and this is the flexor digitorum profundus tendon. So superficial is still here in a first side, and this is the profundus. And also the flexor pollicis longus tendon is also inserting. So these tendons can be the cause of carpal tunnel syndrome. And this is the transverse carpal ligament. If this can be, and this is the intercarpal ligament, this can be. And if there is any fracture or dislocation of the any carpal bone, so that can also create the compression to this tunnel. And after that, the nerve which is gliding, which is coming towards this tunnel, can get compressed, or the nerve itself can swell. There is a, because of that nerve is in the swelling position, it is in the swelled position, so that will also, either the root is jam, or maybe the vehicle is in the not in a working position. So both can affect each other. And like in the pregnant women, because of the fluid retention, that can also be cause of the carpal tunnel syndrome. Because of that, this there is a swelling, so that the nerve is not easily gliding. So these are the things which make the carpal tunnel syndrome completely, a view is completely different, to understand that either only the nerve is the cause of carpal tunnel syndrome, or the walls and the roof, or and the floor, all can be create the shortening or the tightening of this carpal tunnel. Because of that, the nerve cannot glide easily. And there is one more structure, which is when we see about the wrist and hand, that is the anatomical snuff box. Because this is also the patient who are having the problem related to this area in the thumb, they are having a problem. So that time we see that the structures which can be more important to understand about the tendons, extensor, the pollicis longus, extensor pollicis brevis, and the abductor pollicis longus. So all these things, where, because there is a box, there is a just like a you can see it in this is the triangular space that is known as the snuff box. Like in historical history, if we see about the history, that people who eat tobacco, so they keep their tobacco and they just smell in keeping in the snuff box, and they take the smell of that afim type whatever they use. So that kind of the structure, this is the snuff box. And it is very important as a clinical region, because in this also, when hand is in ulnar deviated side, the scaphoid becomes palpable within the snuff box. That enables the, we can palpate if there is any fracture also. And also the pulse of the radial artery can be measured at this point also. So this is also anatomical snuff box, because the patient who are having a tenosynovitis, so that time we check all these things also. And also the patient is having a pain related to the thumb with the abduction or with the extension, so that is also very very important. Or because of a fracture, if there is a fracture in the scaphoid, so that is also, we see all these structure as a part of articular. Then there are the myofascial component, that muscles that which act for the hand, that is known as the intrinsic and the extrinsic muscles. According to their stability structure, that intrinsic muscle which are contained within the region such as in the hand, and extrinsic which are moving from the forearm and originating into the hand. So these are known as the intrinsic and the extrinsic muscle. Then we will see that the vascular supply, that is also very important, that how the wrist joint receive blood from the branches of dorsal and the palmar carpal arches, which are derived from the ulnar. Because there is a one side, there is a ulnar and the radial, so their vascular supply according to ulnar artery and the radial artery. So that will be as a part of the supply also. Because of that, the patient is having a swelling, or as a part of vascular and insufficiency, arterial, venous symptoms. So that also we notice with the hand gripping, that movement, the working of the hand. So if it relief versus it, the patient is feeling tiring, so how the arterial versus the venous insufficiency as a part of vascular supply, we check in the hand. And the nerve supply, yes, there are the three main nerves which are supplying to the hand, that is the median nerve, anterior interosseous branch, radial nerve, which is posteriorly the extensors group of the part where the radial nerve, superficial versus the deep, they supply, and the ulnar nerve, which is in the ulnar side. And then these muscles as a part of the wrist flexion versus the wrist extension. So the group of the muscles, these are the flexor group of the muscle. These are extrinsic muscle, which is in the flexor group of the muscle. Flexor carpi ulnaris, which is coming towards the ulnar side. Flexor carpi radialis, which is coming towards the radial side. And the palmaris longus, which is going towards the palm. And if we talk about the wrist extensor, this is the wrist extensor group where the radial nerve is going to supply in the extensor group. And there also extensor carpi radialis towards the thumb. Extensor carpi radialis brevis till because that is brevis, this is the small, and extensor carpi ulnaris, that is towards the ulnar side. Then we see the radial deviation versus the ulnar deviation. So which muscle? Because if we are doing the radial deviation, so flexor carpi radialis, extensor carpi radialis, they will work. If we check the ulnar deviations, then flexor carpi ulnaris and the extensor carpi ulnaris, they will work. And if we check with the radial deviation, we check with the pronation and the supination. So there is also that according to the axis, the muscles which are the supinator and which are the pronator, they will work with the flexion and extension, because when we do the extension, then supination is easily when we are doing the flexion, so that time the pronation is. So flexion and the pronation is the combo, and extension and the supination is the combo. So that time we see that the extensor group with the flexor group, how they are synergistically work with each other, because if we are doing the extension, so that time they also support the mother, although they are known as the antagonist muscle, but when we do so, automatically the synergy comes with the antagonist muscle side also. So it will be with the, suppose with the extension of the wrist, so that this lumbricals will be, the fingers will be in the flexion position. But when we will do the flexion, so it will be the extensors will be automatically, they will give the straightening to the finger also. So they provide the synergy also that time. This is the slide which I was talking, the synergistic and stabilizing action of the muscles of the wrist. So according to that, that how these extensor muscles of the wrist synergistically work with the flexors of the fingers. So this is the wrist and this is the fingers which provide the synergy because of their action. And with the flexor muscle of the wrist act synergistically with the extensor group of work. So it means when we are doing the flexion, so the extensor group of fingers, they will give the stability, and when we are doing the extension, so that time these, they are in the flexion position, so they will provide the stability, like just holding anything or just for the gripping. So that is the way that these synergy and stabilization action of the work on the muscle of the wrist with the finger. And this is osteokinematics versus the how the bones move with the flexion, extension, and deviation, and how the orthokinematics, how the joints move according to the proximal row of the carpals and the distal row of the carpal. So how they move according to their radial versus ulnar side. And if we talk about the closed pack position, which is the full extension, that is the closed pack position, and the loose pack position is the neutral versus the ulnar deviation. This is the loose pack position. So these are also whenever we see the patient that high hand is in the tightening position with the full extension or in the tightening position, so it means that joint is in the closed back position. And when we are in a neutral, so it will deviate towards the ulnar side, or if it is not deviating towards the ulnar side, then we check about the ulnar negative versus positive variance also. And these are the muscles, the intrapsoas muscle. They are also a very important part of because when we are talking about the gripping, holding the object, that time the training of this intrapsoas muscles are as a distal versus the palmar intrapsoas, both are important, because you can see that these are the palmar, where are the three parts you can see in there, and there are the 1, 2, 3, and the 4, because they will provide the abduction, and these are provide the abduction. Sorry, these are adduction and these are abduction. So according to that, that they need a more space. So according to that, this abduction will coming so towards the dorsal and with the palmar, because we are making it closer as a part of the adductor group of muscles. So they are provide the adduction. So they are coming and they are there. You can see that they are there are just like a leaf like the structure. So how the leaves are coming, so there the leaf, because we more want more expansion, So just like a double leaf, that uh, I forget the term, that what we say, that um, the two side of the leaves, and in this palmar introsoid, this is the single side of the leaf. So these are the things which we see in the palmar.
Bipinnate.
Yeah, bipinnate. Yes, unipinnate and the bipinnate. So according to that, we see in the palmar intrasoi versus the dorsal intrasoi, because here we want to keeping the things closer, we want to hold it, and here we are going towards the abduct. So that time we need the bipinnate structure. So that provide in the dorsal intrasoi muscles. And then we are reaching towards the lumbricals, which are very, very important part of our rehabilitation, our training, how to hold the gripping, and also the training of the tendons of superficial profundus and flexor profundus and the superficial. So their tendons also plays an important role, which we see in this figure, that how we provide the exercises, the gripping strength, how we check with the movement, that how the stability with the lumbricals, then with the all the fingers which is coming in the feast, so that is also way, and with the distal versus middle versus the proximal phalanges, how it works with the tendons of the flexor digitorum profundus versus the superficial. So these are the things also very important part for our training, because these four lumbricals attach proximally to the tendon of all the muscles of profundus and the superficialis. So their training is also very important. If these tendons, they are in there is a tightening and any facial dysfunction, the distortion function, dysfunction in this tendon, so that time also the grip will be weak. So again, with the articular, we have to check with the muscle and the fascia also, that how these tendons they are not providing the gliding of the tendon, and they are in the tightening position. So their attachment also transmit their force to the both flexor and the extensor mechanism also. So if they are weak, so they will disturb the mechanism with the flexion also or with the extension also, because the patient will keep their hand in like this condition, so they will not able to do their finger movement also, and they will not able to do the full extension movement also. So it means these lumbricals provide the flexor and extensor mechanism strong, and if they are weak, so they will not allow the movement of flexion and extension of this fingers movement. And the lumbrical gripping is the weakness for the gripping is because of the weakness of the lumbricals. And this is the muscles of the wrist complex. The muscles have tendons which are crossing the volar aspect. The primary muscles, that longus, flexor carpi radialis, ulnaris, and the secondaries are the flexor digitorum profundus and the flexor pollicis longus. So these are the muscles which are in the flexor group, which are entering with the volar wrist muscles. They are with their tendons, they are entering in the palm. And the extensor group of the muscles, they are the extensor reticulum, like there is a flexor retinaculum, there is a extensor retinaculum, from where the tendons are, these muscle, the extrinsic muscles tendons are entering in the dorsal the side of the hand. So that is with the dorsal introsei also, and the tendons of the extensor pollicis longus, extensor digitorum also, and the abductor digiti minimi means they are entering into the fingers, because the fingers, we know that the pollicis for the thumb and the digiti mini for the fingers, so their tendons are entering in the fingers and also in the thumb also, with the bypassing with the extensor retinaculum, and also with there are the dorsal introsoi, which we have seen that there are the four dorsal introsoi, which also provide the abduction capacity of the hand. So these are the extensor group, which we have seen that how they are crossing with the primary versus the secondary muscle group of the nine muscles. In this, the three are the primary, which are the extensor carpi radialis longus brevis, and also the ulnaris, which is we normally see in the outer side, and the secondary, the muscles which are as a radius communis, indicis proprius or digitorum minimi, and the pollicis brevis, and also the abductor pollicis longus. So as a part of the band, they have mentioned all the group of extensors group, either with the primary versus the secondary. So they are providing the extension for the wrist, and also with the help of the movement of the hand, forearm also, because they are passing from the forearm. So it means if there is a tightness, is any trigger point in the forearm, so that time also they will not allow their functioning properly, because they are tight at their proximal way. So the distally they will not allow the proper working of the extension. So if there is the patient is not able to perform their extension, and then we check in the forearm, so there are the trigger point in the forearm, so that can be our main focus, that we have to release. That's why we use the fasciomuscular release technique, where we gliding the fascia and then we contract the muscle. So that gives us the idea, because the fascia adhesion is in the proximal hand and the muscle contraction is restricted in the distal side. So we have to match it both the things as a part of the proximal versus distal, with the fascia versus the muscles, because if we glide the fascia, then this muscle will be able to work properly. So this is the combination with the extrinsic muscles. We as a proximal versus distal, we have to utilize the myofascial component as a part of the fasciomuscular release. And then we are moving towards the biomechanic, how these movements of the wrist and hand influence each other with their working. So that is also very important part, like in the type of the grasp, arc of the hand, functional position, joints, mechanism of finger flexion, mechanism of finger extension. So these are the thing, and how the muscles that transmit force extensors mechanism. So these are very much, and how the peripheral nerve injuries of the hand, which as a part of our clinical appearance create the pathomechanics. So there are the movements of the wrist, the sagittal and the frontal plane movements, where the rotatory movement is also there, flexion, extension, hyperextension, radial deviation, and the ulnar deviation. So these are the movements which normally we see, and also the gliding movement which we provide as a actively or passively. We can provide the gliding of the rows of the carpal bones, or the radiocarpal, radio and ulnar joint, the distal joint. And in this also the movements of the radiocarpal and the midcarpal joint, where with the flexion versus the extension, that how the distal carpal row move towards the proximal carpal row. You can see it that there, when we are doing the flexion, so that time in the flexion position, this is the that movement is coming in the distal carpal row, move proximal carpal row. So it will move towards that, and the scaphoid will move towards the sorry, this is the scaphoid, this is the capitate, this is the lunate. So how they will move when there is a flexion is coming. So they will also move at their place towards the proximal to the distal. And if there is a, we are doing the extension, so that time the carpals move as a unit of the radius, and there is a the TFCC, that fibrocartilages complex cartilage sheath, triangular sheath, that is also achieved with a full extension position, and then also the scaphoid and lunate, that they will the shift in the extension position. So these movements, when if we want to palpate the scaphoid, the proximal row, so that time this extension position, we take keep it into the extension position, so that time we can easily palpate the scaphoid also. But if we will do the flexion, so that time we cannot palpate the scaphoid bone, or if the patient is having a pain in the distal radial head, so that time it is not able, we cannot palpate. So the movement is in the extension or the hyperextension, it is easily palpable according to the movement of the wrist. And this is the grasp, the type of the grasp, that how the type of the grasp will tell the position and the mobility of the carpometacarpal joints, with the proximal metacarpal joint, metaphalangeal joints. And this is the power and the precision grips, because if we want to hold it with the powerfully, so that time how our hold will be, how we can take the thing, that the bone with the carpal bone and with the finger gripping, so that will create the thing, we can hold it very tightly. But if we want to do some gripping like the grasp, like the precision grasp, where that uh, tying the buttons or the small things we want to hold, so according to that the precision grip grasp we provide. So power versus the precision grasp is more important. Like in the power grip, the adductor pollicis stabilize. This is the adductor pollicis muscle which stabilize an object against the palm, and the hand position is in static position, because this is, we are providing the adduction, because when we will provide the adduction, that time we can suppose I want to hold the pen, so for that I have to just making the adductor pollicis as a stabilizing position. If I want to write some words in the letter and I want to hold the pen, so this grip is very important, where I am keeping my the first fist grip is small and the cylindrical grasp. And if I want to do the spherical grasp, so this is kind of the grasp which is the spherical grasp. And the hook shape grasp, if I want to hold something like in the hook shape, so this is the shape. And if I want to lateral, so that means that I will take my the thumb is in the adducted position, then I can take the lateral prehension. And this is the pinch grip, where I will pinch it with the thumb, because there the opponent's muscles will work and I can pinch it. So if there's a pinching, so that time this thumb versus the digits should be nearer, so that time the pinching grip will be thumb. So this is the prehension of the, you can see it in this, of the hand, the cylindrical grasp. This is the tip, hook off snap, palmer, spherical grasp, where I we want to hold the ball, like this is the spherical grasp. And lateral is for towards the, because which muscle will work in that grip, you can easily understand that what direction of the muscle, either you are holding with the abductor, or you are working with the adductor pollicis longus, or you are with the pinching the tip to tip, you are going to hold the thing. So how the opponent's pollicis will work, so these are the things which tell us that the which the training of the muscles, the strengthening or the lumbricals, how we can train the patient. And this is also very important, that how the precision grip, the muscles are active that abduct or oppose the thumb. The hand's position is dynamic. In this dynamic, because we are writing something. Suppose I want to write on the blackboard, so that time how my hold will be. So my hold will be maybe like to pulp, some kids them when they start writing, so they hold the things like in the just pulp to pulp, like includes the chuck or the chalk and the tripod grips. Tip to tip, where the flexor digitorum profundus is active, because it is reaching towards the distal act, so it will be with the deep flexion, so it will work. And the lateral prehension, pad to side or key grip, so where we just sidely we hold it. So this is the pad to side grip, this is tip to tip grip, and this is the pulp to pulp grip. So this is the things which we where the abduction work is going with the thumb, and the other fingers that did this, they are coming towards the adduction. So that the type of the pre-session grips are important: tip to tip, palm to palm, pulp to pulp, and also the pad to side or the key grip, where we just taking the key in the car, so that time we are just rotating. So that kind of the working, that is known as the lateral prehension grip. And then the mechanism of for the finger flexion, where the role of the flexor digitorum profundus versus the flexor digitorum superficial is more important, because it is that profundus is the deeper of the rows it is going, and the superficial is the more superficial muscle. So although uh, the FDP is deep to the FDS overmost, but it attached to the skeleton more distally, because it passes through the flexor digitorum superficial tendon. So this is the way that you can see it in this, that how these tendons are coming towards the tip and the mid. So their movement can be like this and this. So this is the making the hook like structure. So this is, if we are reaching till here and we are able to perform, it means that we are working on the profundus. And if we are working here, that we are working towards the superficial. And then there are some arches, the three arches in the hand that are also, which provide the stability and mobility of the hand. So the proximal, this is the proximal, this is the distal, and this is the lateral arch. Like in the foot, we have seen the medial and the lateral and the transfer arch in the foot. The same here are also the proximal and the distal and also the longitudinal, which are also maintain the activity of the intrinsic muscles with the help of the maintaining the arches. So the proximal transfer arc is a, you can see that because this is the proximal and this is the distal. So it means it will provide the stability of the carpal bones row, which is in the row is itself is in the proximal and distal, but on towards the distal, this proximal arc is there. So it can be the trapezium on the arc of the radial side with the hamate on the ulnar side. So this is radial side, this is ulnar side. So radial side, this arc is towards the trapezium and towards the ulnar side towards the hamate, and they are making the anterior border of the carpal tunnel also, because here is the carpal tunnel also. So this proximal arc is making the border for the carpal tunnel also, and they are making the boundaries for the proximal and distal row of the carpal. And this is the distal transfer car. It is also called the metacarpal because now it is in the metacarpal side. So this is also formed by the metacarpal heads. Metacarpals 2, this is 2 and the 3 are stable, while the 4 and 5 are relatively mobile fingers. So these are stable and these are mobile, and you can observe this arched combination of the stability of the radial side versus the ulnar side in the loose back or the close back position of the fist. And this is the longitudinal arch, which is running toward the run with the length of the hand and formed by the shape of the metacarpus and the fingers. So it is running, you can see in this picture that how this longitudinal arc, it is coming towards the finger and it is crossing like a, these are the bridges, which is proximal versus the distal arc, and this is the longitudinal arc which is crossing towards. So it will also provide the stability. So it is coming like this structure. And then mechanism, sorry. So these are the mechanism of the finger flexion, which is completely related to the FDP and the FDS according to their attachment of the tendon with the proximal versus the distal part of the palm. And this is the finger extension where we can extend the proximal interphalangeal, distal interphalangeal joint without also extending the medial phalangeal joints, but we cannot extend the pip joint without extending the dip joint. So this is the way that same time if we want to extend the pip joint, so we have to extend the dip joint also. So this is the way. So both will be in the extended way. And flexing only the dip joint without also flexing the pip joint is very difficult, because if we will flex, so definitely it will be also coming in the flexing joint. So these are the thing, the mechanism for finger extension, and the full active and passive flexion of the pip joint prevents active extension of the dip joint. So it will be in the extended position because of the convex concave rule of these bone, where the metacarpal versus this phalangeal joint. So that are also with their ligaments are also there, and their concavity versus the convexity will be the rolling and the gliding will be, because these are the concave, so it will be in the same direction. And this is that how we make the immobilize the patient's hand when they are having a position, and during a period of immobilization, the resting length of the hand position provide the best balance, length and the force. So these things are test the arch, the finger movement, the gripping movement. So that also gives us the idea that in which direction we are going to provide the rehabilitation for the gripping. And force transmission also, that how we transmit the pattern of the force with the wrist position, because when we want to come up from the bed, so we keep our wrist on the bed and then we take the load. So that is also that how the ligaments and the capsules take the provide the stability and they take the load of our body, and after that we turn from the bed or we want to come out from the bed, and that time these articular surface plays a major role and this ligament stability plays a very major role. And then all these things, after that we will see that what are the pathomechanics of wrist and hand. And there are so many structures. We cannot say that there are only the neural structure or the articular structure, because there are so many words which whenever we think about the wrist and hand, that comes in our mind, that there is a wrist sprain can be, maybe there any ganglionic wrist is there, maybe wrist that tenosynovitis is there, tendinitis is there, cubital tunnel syndrome because of the elbow, so the patient is having a pain towards the hand, carpal tunnel syndrome, or maybe the forced fracture, the wrist fracture, if we are having a fall on the wrist, so that time there is a fracture of maybe the distal end of the radius, or maybe the carpal fracture is there. So these can be the cause for the wrist and hand pain. And in this, the main which we focus on the peripheral nerve injuries in the hand because of the median nerve, which is the carpal tunnel syndrome, which is very common and we are familiar. And in this also, that decrease the thumb function is especially in the opposition, and thumb moves into, because we know that the movement of the thumb is opponents also, abduction, adduction also, or when that's the supply of median nerve in the thumb also. So because of that, or autonomic symptoms are, fibers are also in the median nerve, so the swelling is there, edema is there, the patient hand color is changed, or maybe vascularity. So because of that, that median nerve can be in the entrapment. And also the first is in the spine, the cervical spine, there is a cervical radiculopathy. After that, there is a nerve entrapment, the cubital tunnel syndrome, or maybe the carpal tunnel syndrome, because of these nerve entrapment in the cervical spine, radiculopathy, and then there is a nerve entrapment for the elbow or in the wrist and hand also. And this is the ulnar nerve. Damage to the ulnar nerve can occur with the trauma of to the elbow region. So the ulnar neuropathy is also the create a complication and wasting of the web space in the interosseous space also. So the adducting finger is painful. So that give us the idea that there is a affects the adductor pollicis and ulnar head of flexor profundus, uh, pollicis brevis. That can also be because the muscles, the flexor group of the muscle, which is coming towards the ulnar side, they can be, the muscles can be in the tightness because of the nerve. After that, the muscles are in the tightness, so it will also create a entrapment for the nerve also. So the patient is having, when we check from the medial epicondyle of the elbow and we check the ulnar nerve, if the patient is having a numbness, tingling sensation and numbness in the pinky finger, so it tell us the idea that there is a ulnar nerve entrapment is there. So the patient is having a numbness because of the ulnar nerve. Gripping will be weak because it is supplying to the lumbricals also. It is the radial nerve injuries, which is the extensor group of the nerve where the radial nerve is supplying, and also the extensor muscles are weak, so the wrist drop is there. So the radial nerve supply with the extensor muscle, which allow the extension of the wrist and fingers in addition to supplying the tricep group of the muscle also. And this is if there is a nerve entrapment of the radial nerve, that is known as the Saturday night palsy also. And in this also, the dropping of the wrist cannot, and the reposition of the thumb and lack of the wrist extension may cause hand grip to be weak also. So the radial nerve palsy, which is also known as the Saturday night palsy, where the loss of extension of the fingers, thumb and the wrist, and numbness over the our dorsal interosseous muscle also. And this is carpal tunnel syndrome, which we have already seen in our anatomical part, that how these tendons, normal, these are the tendons, and this is if there is a carpal tunnel syndrome. So that how the median nerve is compressed, transfer carpal ligaments, these are the tendons, and this is the way that nerve is coming here. If there is a entrapment of the nerve because of the nerve is enlarged, or maybe the tightness of this because of these tendon, so because of that the way is blocked, so the nerve is not getting the gliding. So in this also, the swelling of the flexor tendons and the maybe the edema is there in the surrounding of the soft tissues, and which reduce the available space for the median nerve. And then after that, there is a wrist and the hand deformities. There are so many deformities which related to the hand and the fingers also, like the mallet finger where the axial compression injury is there, inability to actively straighten the or extend the distal interphalangeal joint due to the rupture of the tendon and connectivity of the muscle to the distal phalanx. So this can be possible if there is a trigger finger, which is the overuse injury involving the digital flexion. Digital the flexion will be not possible, and inflammation of the tendon, that is because of the tendinitis, or the tendon sheath, that is the tenosynovitis. So maybe this tendon will be stuck in that position, so the finger will be in the triggering position and it will trigger, and that affected finger can still be straightened actively or passively, but it may be difficult. We can do it, but after that, sometime it will be go back to their place, like the deputrian, the contracture. In that, we cannot take the finger back to their place, but in the trigger finger, if we want to actively, passively, we can take it to their position. But after that, when because the tendon is already in the stucking position, so it will, while short time, it will come back in again in that position. And in this deputrian contracture, which is maybe the hereditary, or maybe there is a nodules begin to appear in the tendon, which leads to the thickening of the tendons, which we have seen in the tendons which is passing, and the collateral ligament and the cruciform structure. So that also there is a the tendons is stuck in that position, and contracture is unable to, because contracture is known is mainly we focus for the fascia, the shortening of the fascia, that is known as the contracture. So the fascia is in the shortened position, so it is difficult to take the fascia in their proper place. So that because of that, this is irreversible, that we cannot take it into back to their place position, because here the fascia is already in the contracted form. So how it will be coming into their place? If it will not coming in their place, so that tendon cannot glide in that particular place. Or because of these, there are some other terms which we see for the fingers, like the swan neck deformity, rheumatoid arthritis, where the wrist radial drift digital, and the patient is having because of rheumatoid arthritis, that is the inflammatory disease. So that time also the fingers take the shapes, the shape is changed in the swan neck deformity, botnier deformity. So these are the things which the deformity comes in the finger, like the claw hand and the trigger and the botnier or the swan neck deformity. So this is the common hand deformities because of the crepitation, grating, crunching, popping sensation, sound in the joint, osteoarthritis, rheumatoid arthritis, where the osteophyte formation, the bony spur that form all along the joint. So that will not allow the movement of the fingers, or they will be, the tendons will be stuck in that position. That is also, you can see that the Bouchard's knots in the proximal interphalangeal joint and the Haberden knots in the distal phalangeal joint. So these are kind of the nodules, just like a pulse. They made it so they will not allow the movement, the gliding of these tendons, so that they will stuck in that position. And the patient, when the crepitus will come, popping sensation will come because of osteoarthritis, because this is the degenerative changes in the bones and the cartilages, and maybe the bone spurs are formed. So because of that, the morning stiffness is there, the patient is not able to open their fingers because of the morning stiffness, and because the thickening of that synovial fluid, and as the day is gone, the passes, so that time this fluid is start working, and then the movement will come in their normal way. So this is the botnier deformity, where you can see that the flexion, and this is the extension, that how the botnier deformity is coming. This is the flexion, you can see the tendon, and this is in the extension position. So flexion and extension. This is the trigger finger, where this finger is in the trigger position. Because of the tendon, the pulley is not working, the tendon nodule will not allow the movement. So this is the trigger finger. And this is the fusiform swelling because of the rheumatoid arthritis, the swelling in the hand, and this is the swan neck. So there is also the proximal phalanges hyperextension, flexion and hyperextension, and this is the flexion, just like a shape of the swan, that bird. So because of that, the swan neck deformity is the name for this kind of position. And this is because of the rheumatoid arthritis, fingers in the swan neck. This is flexion, this is hyperextension, fingers in bottom arthritis. So these are the conditions which we see in the deformities in the fingers. So this is the distal interphalangeal joint deformity, mallet finger, hyperflex distal interphalangeal joint due to the rupture of extensor slip. This is the Dupuytren contracture. This you can see that this disorder is marked by the broad scar-like tissue band that form inside the palm, extending into the finger. So this is tendon sheath, and this is like contracture, the shortening of the fascia, so it will not allow the working. This is flexor tenosynovitis, the inflammation, volar surface of the wrist and the finger, fusiform swelling of one or more flexor tendon sheath, which is towards the middle of the palm and the distal interphalangeal joint. And this swelling is typically painful and cause gradual decrease in the flexion, and the synovium is thickened and nodules can be felt along the tendon sheath. So here they will feel that and there are some nodules. So it will also not allow the working, the swelling because of the swelling also. So this is the inflammation in the tendons. So that is also the flexion will not be possible. And this is the claw hand, inability to extend the interphalangeal joints when extending the fingers. So this kind of that the claw, like the bird's hands. So unopposed action of the extensors and flexor digitorum profundus because it is supplying towards that. So lumbricals of digit and they are in the just like a paralyzed situation. Like so the some doctors suggested the splints also lumbrical flex the metacarpal phalanges and the extend the interphalangeal joints. So that is also that because of the clawing of hand is coming in this deformity. And the ape hand deformity, that is also where the thumb, this is in just like a ape like that because we can do abduction adduction, but if there is a ape hand deformity, thumb in adduction and extension, thumb web space contract, the loss of opposition, fingers show tropic changes, slight clawing of index middle fingers because of the loss of the lumbrical innervation. So the hand will be like in this position. So this is ape, and this is mallet finger, you can see it here, there, in the distal interphalangeal joint. So how this finger is in the flex position, as you can see. This. And this is carpal tunnel versus arthritis because in osteoarthritis, the degeneration of changes of the joints in the morning stiffness. In rheumatoid arthritis, there is an inflammation in the joints, and in the carpal tunnel syndrome, there is a swelling near the carpal tunnel. So these are the things which we see in our patient with the mix and match symptoms also with the osteoarthritis, rheumatoid arthritis, or with the carpal tunnel syndrome. And this is gout arthritis. So you can see it here, arthritis, redness and the swellings of the affected joint. And this is types of wrist sprains with the grade 1 sprain, mild, common sprain, slighting, stretching, and tiny tears to the ligaments, along with the swelling. Grade 2 sprain, where the moderate sprain with the partial tear of the ligaments, maybe significant swelling and the tenderness. And the grade 3, the ligaments which are in the intense swelling and the pain needs immediate medical attention because then if there is a grade 3 sprain, so the ligaments are not providing the stability and they are completely torn. So the movements of the wrist and hand is restricted. So that is the grade 3 of the sprain. And this is anatomical snub box, so that how the tenosynovitis that the patient feel the pain in the extensor retinaculum and where the abductor pollicis longus versus the extensor pollicis brevis and the extensor pollicis longus. So they are getting the less space, and because of that the patient is having a inflammation in this tendon, so the patient is not able to move their thumb in the direction of the abduction adduction or in the extension. And then there are some the different view of AMPT, how we treat the patient if they are having a wrist and hand dysfunction, or maybe the forearm pain is there. So versus the extrinsic versus the intrinsic muscle. So that is also important part here as a part of our surface anatomy with the unilateral versus the bilateral assessment is important. Either the problem is because of the structure or the heredity, or the patient is having a functional restriction is there, so they are not able to perform. So because of that the bilateral assessment according to the structure, articular, myofascial and neural, is very very important to check the patient problem. Either the pain is the primary is articular because of the myofascial component is there, and then the neural component. And also that how we can provide a better rehabilitation to understand with the myofascial components, muscle contractions, and how with the facial gliding we can see we can use the adjuncts like the ISTM, cupping, taping. So that can also enhance our working, our clinical practice to understand the mechanism that what is the role of the fascia, what is the role of the muscle, so how that muscle and the fascia combination we can give a better treatment. So these things we add as the learning from the AMPT, that we work on that active approach. So active is the kinetic force, which is the for the muscle. So for the muscle and the fascia, how we can provide the proper functioning to the patient. So that is also very important part. Before that, going to that, it is important to understand that how we can check the fascia. Either the guiding is restricted in the proximal direction or in the distal direction. Because of this spatial restriction, why the muscle is not able to perform. So which the muscle or the fascia is carrying the way. So how we can check both the things. And then the minor manual therapy according to the articular, myofascial and the neural, how we can, if the patient is having a articular, the capsule, joints, ligament, bones, they are having a problem with us when we do the surface palpation with the tenderness. So that time we see that after maybe the fracture or maybe there are the ligaments which providing the instability. So to check all these part articular structures, so how we can provide the gliding, the mobilization with the grading, with the pain versus restriction, or with the mobilization, with the movement. Because when we are providing the movement is restriction is there. So mobilization with movement in which direction we are providing. So there the mobilization belt we can use it. We can by the hand we can give the glides as a part of the convex concave rule. So that also, and simultaneously we can add other techniques, the adjuncts also in this direction, and provide the stability to that particular articular structure. And this is the manual therapy for the muscle, where the TheraBand is for the muscle contraction. If we check the muscle contraction, the patient is getting relief by giving the muscle contraction with the flexion or with the extension. So it means that the patient is in the need of the muscle treatment, where we have having a manual therapy approach for myofascial release, fasciomuscular release, muscle energy technique, all the urgents that we can utilize it. With the TheraBand we can give the training. We can train the external rotation, internal rotation, or the extension flexion, that also we can treat as a part of the manual therapy. So it is better for upgrading yourself. You can take the courses that our myofascial courses, the muscle related, the muscle and the fascia, where the full courses, the myofascial release that sir has explained for all these things, all the technique for the manual therapy for the myofascial component. And the motor control retraining, because we know that the lumbrical weakness is there, the patient is not able to grip the thing, they cannot hold the thing. So that time the the lumbricals, because if we will train the patient, they will not take their hand in this position. So how we train with the motor control, with the pressure biofeedback, we can train the patient to, so that they can keep their hand in this position as the making the angle of the 90-degree. So that is also the, or for if there is a weakness in the finger, so that also we can provide the stability. So there are so many things as a part of the motor control retraining, because um the gripping is not only because of this lumbrical weakness. Maybe there are the myokinetic therapy is also important here, and also there may be the functional interdependence, where the visceral organs can be the cause for the weakness of the grip. Maybe the diaphragm weakness. So if we give the we treat the diaphragm, after that the patient is having a right grip, so it means there is a viscera were affecting the somatic fiber. So that is also very important to check. That is the main role of AMPT. We check with the structural influence, regional influence, and also the we check with the functional influence. So that is with the visceral, cranium, with the somatic. So these things also very important. Or for the wrist and hand, we can use the mirror therapy, we can use the graded imagery. So that is also very much important part of, as a part of the central mechanism, as a part of central sensitization, or maybe the cognitive effective that we add as a pain based mechanism. There also we provide the hand training. So this is all about the view of the wrist and hand, and also the pain-based mechanism. We work on that also, and because we know that the functional unit of the hand, the gripping, the hold is very, very important part. The movement, either we want to hold it from the direction of the shoulder, external rotation, that time we hold. So that also the chain, the full chain will work with the shoulder, with the elbow, and with the hand. So this way, that if we want to hyperextension or flexion, so that neural component from the cervical spine to the hand, till that neural component is also all the muscle, the flexor group of the muscles, or extensor group of the muscle, internal rotators and external rotators. So they all will work till the hand. So that is also very important part of our learning, to make the link in between all these things, that the patient who are having a primary the shoulder problem, and after that they are having a wrist and hand problem. So it means there is between the elbow, which can the crossing joint from shoulder to hand. So we have to check the full bridging view, the myokinetic chain. We have to check all these components, then we can treat our patient in a better, and we can train our patient in the for the better recovery, for the rehabilitation for wrist and hand. So thank you so much, everyone, and thank you to you, sir, for giving me this opportunity to understand and try to understand about the wrist and hand, so that we can correlate with so many things, with the elbow also and with the shoulder also. So thank you so much, sir.
So today's webinar is much more concise, I can say. Although participants will be feeling that it's a full journey, hand in hand, with the information, knowledge, graphics, okay, and also at every level, you can see that important points Madam was repeating. Okay, so it was repeating at anatomy, mechanics, and also the disorder, and also during treatment. And the screenshots from COMT Chennai again would have given an overview for the clinical COMT participants, that we are going to see something higher than those things what you listen today. And we have the graduates, of course, they are all gearing up for the graduation ceremony. And it's indeed a special moment for the academy also. And we have a different method of celebrating the new year by holding the CCOMT graduation on the 7th of January. So wishing all the participants, and of course, Madam, for her I can say she has to multiply her potential and passion. What sometimes what happens is when we have 10 things to do, we divide ourselves into 10. But people like Madam, if there are 20 things, she becomes 20 times more stronger. That capability should be again be back with a bang in this 2024. And also our members, of course, to upgrade and also to utilize the knowledge more in clinical dimension and come back with better discussions and webinars throughout the year. As we always saw every year, where there was a year where we started with the osteo and the Cairo, the 2023, and then we went on to the COMT and the CCOMT. Okay. So same like that, we actually are parallelly holding the Pondicherry CCOMT and also the Kolkata Cairo manual and the osteo manual certification course, the 6 months, both of them. And then in between, we'll be venturing into various other innovative treatment and therapeutic approaches. So wishing all of you the best of course, the 2023 to learn from and the 2024 to, I can say, to explore your own inner potential much, much better in the coming year through learning and also through your experiences. So God bless you all. And let's close this session today.
Yes,
Yes,
sir.
ma'am.
Yes, sir. Thank you so much, sir. Thank you, everyone. Yes, sir.